Okay, I guess we can start. It's great to see everyone is still awake after lunch. And I'm sure the great cases that will be shown to you will wake you up even further. I don't know if our first presenter, Dr. Michalová, is available and ready. So, Dr. Michalová.
So good afternoon, everyone. First of all, I would like to thank for the opportunity to speak at this beautiful event. My case is quite quick and simple, I guess. It is a tumor of the liver, which arises in 24-year-old woman. It was a solitary lesion. It was 24 centimeters in the largest dimension, and from the gross point of view, it has elastic consistency, and there were extensive central located ossified areas. Unfortunately, we didn't have any further clinical information on, or follow-up information for this patient. From the histological point of view, here's a low power where we can appreciate tumor nests of tumor cells, organoid nests of tumor cells embedded in myofibroblastic stroma. Here is a higher magnification. We can also appreciate the nests of epithelioid to spindle tumor cells, which are surrounded by variably prominent myofibroblastic proliferation. Here is more or less the same picture, so epithelioid to spindle tumor cells and myofibroblastic stroma surrounding the each pack of tumor cells. At this slide, there is also adjacent liver parenchyma, which was completely normal. There were no signs of fibrosis or other liver disease, and quite a frequent feature in this tumor were entrapped benign or benign non-neoplastic bile ducts. At this picture, there is once again a detailed area of nest of tumor cells. So we can see again spindle to epithelioid cells. The cytoplasm was eosinophilic to pale, and the overall appearance of the tumor was bland. There was no lymphovascular invasion detected, there were no tumor necrosis, and the mitotic activity was very low, up to 1 mitosis per 10 high power fields. Immunohistochemically, there was a positive reaction with CD56, WT1, and broad spectrum cytokeratins, and there was a negativity for hepatocellular markers, namely arginase 1 and hepar1. Also, neuroendocrine markers were negative, INSM1, synaptophysin, and chromographs were performed all negative, and also beta-catenin was negative, or there was only cytoplasmic positivity, no aberrant nuclear staining was observed. We then performed NGS analysis, which revealed pathogenic WT1 mutations together with third promoter mutations. There were no CTNMB1 mutations, no fusion transcripts, and no copy number alterations detected in this tumor. So taken together, morphology, immunophenotype, and NGS findings, the final diagnosis of this case was calcifying nested stromal epithelial tumor of the liver, which is a very rare primary liver tumor with uncertain histogenesis. This tumor has a predilection for children and young adults, preferentially females, which corresponds with our case, which occurred in a 24-year-old woman. Also, from the histological point of view, our case was quite characteristic, revealing biphasic morphology. It was composed of spindle to epithelioid tumor cells embedded in cellular variably prominent myofibroblastic stroma. Immunohistochemically, our case was also characteristic. It was and the published cases had the similar immunophenotype, namely the positivity for WT1, CD56, CD56 broad spectrum cytokeratins, and which wasn't observed in our case, but is observed in most published cases, is aberrant expression of beta-catenin. Our case didn't have it, it had only cytoplasmic normal staining for beta-catenin. And also negativity for hepatocellular and the neuroendocrine markers are required for this diagnosis, which was also observed in our case. Given the rarity of this calcifying nested epithelial tumor of the liver, there is quite limited information regarding molecular features and biological behavior. To date, only 10 cases have been molecularly analyzed in 2 separate studies, which you can see here. The first study comes from 2012. There were 2 cases of calcifying nested stromal epithelial tumor examined, and the molecular analysis was aimed only to CTNNB1 mutations, which were detected in both studied cases. And the second publication comes from 2021. It was performed by David Papke and colleagues, and this is the only comprehensive molecular analysis performed on these tumors to date. And the CTNNB1 mutation was revealed or detected in all tested cases, and also TERT promoter alterations were detected. So taken together, to date, all of the tested cases of calcifying nested stromal epithelial tumor of the liver were positive for CTNNB1 mutations, and also TERT promoter mutations was detected in all tested cases. Contrary to traditional view on this tumor, that this is indolent tumor, the recent publications are saying us rather the opposite, or probably the opposite. Most patients with available follow-up in these publications revealed distant metastasis and were mostly unresponsive to chemotherapy. These aggressive cases usually had higher mitotic activity and or lymphovascular invasion, but otherwise these were histologically indistinguishable from the indolent tumors. So coming back to our case of calcifying nested stromal epithelial tumor of the liver, our case was slightly different from the published cases, especially because of the fact that it was CTNNB1 wild type, and there were TERT promoter mutations and WT mutations instead. Actually, we currently performed a study which is ready for submission, including 2 cases of calcifying nested stromal epithelial tumor of the liver. The red case I'm presenting to you right now had these genetic alterations, and the second included case was more typical to the published data because it had CTNNB1 mutations. But the presence or the occurrence of a CTNNB1 wild type case challenges the notion of CTNNB1 mutations as a universal feature of this rare tumor. Probably there can be alternative pathways involving TERT mutations and WT1 mutations that can drive the development of calcifying nested stromal epithelial tumor of the liver. We cannot comment on biological behavior too much in these 2 cases of calcifying nested stromal epithelial tumor of the liver, because we have very limited follow-up. For the current case I'm presenting to you, there was no available follow-up or other clinical information, and for the remaining case, which had CTNNB1 mutations, this case had extensive lymphovascular invasions. It was resected, and the patient had 21-month uneventful follow-up, but then she was lost for follow-up. So it is not possible right now to say whether these gene mutations impact somewhat biological behavior. But because of the published risk of malignant behavior and also resistance to chemotherapy, it is crucial to understand the molecular genetic background of this tumor, which might be used to therapeutic options. And involvement of beta-catenin signaling pathways and WT1 mutations and TERT promoter mutations might be then useful in exploring the potential targeted therapy options. Because of the rarity of calcifying nested stromal tumor of the liver, the epigenomic characteristics of this tumor are currently unknown, as well as the histogenesis of this tumor. So we performed methylation profiling with the aim to assess the distinctness of calcifying nested stromal tumor by comparing it to morphologically similar tumors. First of all, the included entity was hepatoblastoma, which is a tumor frequently included in differential diagnosis of calcifying stromal epithelial tumor of the liver, because this the hepatoblastoma arises in young individuals. Frequently, it expresses beta-catenin and has CTNB1 mutations, and one subtype of hepatoblastoma is also quite morphologically similar to calcifying stromal epithelial tumor of the liver. And we also included in methylation analysis solid pseudopapillary neoplasm of the pancreas, which is a tumor not usually included in traditional differential diagnostic options, but because the SPN of the pancreas also has a predilection to occur in young female individuals, and there are consistent CTNB1 mutations, and also from the morphological point of view, this tumor is not dissimilar from calcifying stromal epithelial tumor of the liver. We included also this case. Together with other similar or with other entities occurring in the liver, especially in young categories of patients, to make the methylation more reliable, and here are the results. These are so far unpublished observations, but it will be published soon, or at least hopefully it will be published, accepted somewhere. The methylation analysis reveals clear separation of tumors in distinct clusters. Here you can appreciate in this dark green color the presence of two cases of calcifying nested stromal epithelial tumor of the liver. Here in the yellow color or dark yellow is solid pseudopapillary neoplasm of the pancreas. This pink cluster represents hepatoblastoma, and here are other included entities. Here is a group of entities included in the methylation analysis. The methylation data were downloaded from the widely from the database available online. The results of methylation analysis showed us that there are robust epigenetic differences in included entities, which supports the unique nature of calcifying nested stromal epithelial tumor of the liver. So in summary, the known genetic landscape of calcifying nested stromal epithelial tumor of the liver was in a presented case or in the current study expanded beyond the known CTNB1 mutations and TERT promoter mutations to include WT1 mutations. And because of this finding of CTNB1 wild type case, there might exist a genetic distinct group of calcifying nested stromal epithelial tumor, and it suggests that there might be a potential molecular heterogeneity within this rare tumor. It could have implications for the clinical behavior, including metastatic potential and chemotherapy resistance, but given the limited follow-up for the current cases, we can't relevantly comment on this right now. Understanding the precise interplay of genetic alterations might be crucial for developing more targeted therapies and effective therapeutic strategies, especially that the current studies showed us that these tumors are probably potential aggressive and resistant to systemic untargeted therapies. And also including TERT and potentially also WT1 mutations in diagnostic molecular panels might be helpful for diagnostic accuracy, because there can be also cases which lack CTNB1 mutations, so it is better to reliably diagnose such cases to include more genes than only CTNB1. And lastly, the performed methylation analysis showed us that calcifying nested epithelial tumor of the liver is epigenetically distinct from morphologically similar entities, and because it shows a different epigenetic signature from the entities included in methylation analysis. So that's all from my side. Thank you for listening.
Very nice case and presentation. Questions, comments? Did you have a chance to do progesterone receptors, considering some of the analogies with in the girls?
If I performed receptors?
Progesterone receptors?
No, I did not perform any receptors, and the blog is consumed,
It won't change anything, it was just a curiosity whether that could be something. Do you think these are just offshoot of hepatoblastomas after all? I mean, they're distinct tumors, but they're kind of maybe flagellantically related, or?
I don't think so. Our geneticists explained me the result of methylation analysis that when the groups are close in the methylation analysis graph, it does not say to us that these are similar tumors. That it depends on the graphic illustration of the tumor, and that the relevant information is how close are the dots of the one entity. So regarding this analysis, these are distinct, different epigenetically, and also the morphology is not very similar.
Right. They're very different, but it's childhood and it's it's clearly a distinct entity, but could there be some relationship there? Any other questions, comments? So if not, then we'll move on to our next presenter, Dr. Salviato.
Okay, thank you to Michalová to organize this wonderful meeting, and to everybody to permit me to have this presentation. As everybody knows, I'm from Venice, where we had the last meeting, a wonderful place, and now for job I moved in Naples. Both of them face the sea, and they're both wonderful places where to live and to work. And of course they are twins, and both are maritime republics. We have 4 maritime republics in Italy. One is Venice, one is Genova, one is Pisa, and one is Amalfi near Naples. And here is my place of where I work. It's the unit of Pathology, National Cancer Institute of Pascale in Naples. And this is the story of a 20-year-old woman with a known history of neurofibromatosis type 1 who presented with abdominal discomfort. And the ultrasound revealed an enlarged appendix confirmed by CT scan. So due to suspicion of an appendiceal neoplasia, the patient underwent an atypical resection. And the surgical specimen consists of 3.5 cm segmental ossicon, a 17 centimeter long appendix, and the appendix shows a markedly narrow lumen, contains mucus, and displays a thickened wall. This is a macro section where the thickness is 2.5 centimeters in the dimension. And the appendix wall has its widespread dense fasciculated fibrostromal cellular proliferation, and the proliferation shows occasional wall patterns and features wavy prepucycle-like elements. And within the fibroconnective matrix, dystrophic and sometimes enlarged ganglionic structures were observed, and some ganglia are clustered and shows pinucleation. The fibroconnective proliferation extends to throughout the entire wall. It's prominent in the subepithelial region, and cytological figures, we have no evidence of necrosis or significant atypia, no atypical mitotic figures, and the Ki67 index reflects a low cytoproliferative activity. Ganglion cells were positive for S100 and synaptophysin, and neurons are positive for S100. So findings support a benign proliferation consistent with ganglioneuroma. Hypertrophic nerve trunks were present at the periphery of some section, and surgical margin shows colonic mucosa. Immunohistochemistry S100 was positive, synaptophysin was positive, while GFIP and caldesmon were negative. So here we can see at high magnification S100 positivity of the cell and synaptophysin. Ganglioneuromas are rare, benign, and slow-growing tumors that originate from neural crest cells and belong to the neuroblastic tumor spectrum, having minimal malignant potential. So ganglioneuroma can occur in various anatomical sites. GI tract involvement is rare, and appendiceal ganglioneuromas are extremely rare. So they are composed of mature ganglion cells, neurites, Schwann cell, fibrous tissue, and they lack immature neuroblast and mitotic activity. They were first described by Laurent in 1870, and the incidence is 1 in every 1 million people. Slight female predominance, 3.2 ratio, and most cases are diagnosed before age 20. Of course, ganglioneuromas are uncommon, and the study by Collins reviewed 71,000 appendiceal specimens, and he identified only 119 cases of ganglioneuromas, and none caused luminal obstruction. Appendiceal ganglioneuroma may mimic acute appendicitis, and often they are incidentally found during surgery or autopsy. So, in neurofibromatosis 1, they may be linked with multiple endocrine neoplasm type 2B, Pilsen syndrome, as Vanya told this morning, and rarely with neurofibromatosis type 2. Neurofibromatosis type 1 is an autosomal dominant disorder marked by cutaneous neurofibromas, cafe-au-lait spots, and high risk of GI involvement. GI complications are present in 25% of neurofibromatosis type 1 patients, but most affected are jejunum and stomach, while appendix involvement is extremely rare. So appendiceal ganglioneuroma often presents with non-specific symptoms, and the symptoms do not clearly point to a diagnosis. So obtaining tissue samples through colonoscopy is challenging, of course, and this limited the ability to confirm the diagnosis before surgery. So the unclear presentation increases the likelihood of diagnosis errors, and the surgical resection is frequently used. It serves not only for diagnosis, but also as a treatment. Differential diagnosis, of course, at low power, can be with adenocarcinoma of the appendix, especially when there is a desmoplastic stroma, but of course it's negative for S100 and synaptophysin. Also with mucinous neoplasm, because when we see a low power, it can mimic, but of course it lacks of S100 positivity. With carcinoid tumor, because it's synaptophysin positive and CD55 positive, but of course it's S100 negative. And low power with lymphoma, of course lymphoma is negative for S100. With GIST, of course it is positive for c-KIT end of 1 and negative for S100 and synaptophysin. In perineuroma, in fact, it is also negative for S100. Also with mucosal Schwann cell hematoma, that is positive for S100, but ganglioneuroma has ganglion cell that lack in mucosal Schwann cell hematoma. So given to overlapping clinical presentation, it is often difficult to distinguish appendiceal ganglioneromas from other conditions based on symptoms alone. And accurate diagnosis requires a combination of histopathological examination and immunohistochemical analysis. Of course, surgery is generally considered the standard treatment for ganglioneroma. Recent retrospective studies have questioned whether operative treatment is necessary in all cases of ganglioneromas, but due to the rarity of appendiceal ganglioneroma and the challenges in obtaining reliable preoperative diagnosis, surgical excision remains the preferred option, and the main goals of surgery are to rule out malignancies to prevent potential complication. And to close, pizza is a must if you come in Naples, and because a lot of people here are soccer passionate, Naples won the championship, so for everybody, thank you for listening.
Another very interesting case. Questions, comments? Tiziana, with lesser version of this mucosal neuroma-like things we see in appendices, and some people justify it with or dignify it with the name neurogenic appendicopathy and stuff. Do you use that term? Do you think those small neural proliferations like mucosal neuroma in the appendix, do you ignore them or do you report them? Do you care about them? This is a very striking example of much more than that.
Yeah, but sometimes people even skip because they don't know.
Yeah.
So probably we miss a lot of cases.
Yeah. Has anybody seen any case that's similar to this? It's really a fascinating example. Yeah. I guess, thank you so much. We will move to our next speaker, Dr. Hartley, presenting.
Good afternoon, everybody. So this one's also a liver mass, 63-year-old man this time. Get this thing. And not much, it is a consult case with too much history, but it almost looks like the previous case sort of rotated, but I promise this is a different one. There's some necrosis here, so pretty high grade. Probably feel some good idea of the diagnosis is, but again, very neuroendocrine morphology, sort of sheets of cells, some cords. You can even sort of see some molding. Vertebral body arrangement of some of the cells. Keratin A1, A3, sort of attenuated pattern. This amount of keratin you can see even in melanomas and a lot of sarcomas, and even more than this amount. So not incredibly helpful, but synaptophysin was completely negative, as was chromogranin. And INSM1 had patchy rare single cells are positive. So I should mention CD45 was negative as well. So, you know, I've had a couple, so this small cell carcinoma would be the most accurate diagnosis, I guess, without history makes a question. I did an EWSR one fish, because I've had 2 cases that looked like this and had a little bit of keratin, and actually a little bit of synapto as well. So that ended up being negative. But CD6 strong diffuse positive is, you know, this is the least specific of all the neuroendocrine markers. It's really sort of more of a neuroectodermal marker. It's, you know, commonly expressed in melanomas. It's expressed strongly in multiple myeloma, plasmacytomas. So it's a really broad sort of non-specific marker. But, you know, it can be useful if all the other neuroendocrine markers are negative and you're favoring neuroendocrine carcinoma. RB is lost in this, so that really pushes it even further towards small cell carcinoma. It also had quite classic morphology, as I was mentioning. So this has been a known phenomenon, you know, at least 30, 40 years that small cell carcinoma, about 10% of them lack expression of neuroendocrine markers. Yeah, I remember it being one of the first examples of, you know, as a trainee or even starting out practice, that you can, sometimes the stains will tell you what you want and you just ignore it and you call it what it looks like morphologically, and that's, you know, the routine practice for these. So, you know, just disregarding what the immunos are telling you in favor of the morphology. RB loss is very helpful as well, as more than 90% of small cell carcinomas lose RB, and it also causes strong diffuse expression block positivity for P16, so loss of RB through, you know, sort of large chromosomal deletions. I think it's chromosome 15, but I'm not entirely sure on that. But anyways, that's another method by which P16 becomes upregulated. So another reason why I guess P16 is non-specific in the case of HPV. But for this particular type of small cell carcinoma, there's another helpful stain now, which allegedly is pronounced PAL 2F3, but I prefer to call it POOF, because I just think that is more, you know, easier to remember too. PAL 2F3 is a little, so anyways, that's, so normally every cell should actually be negative for PAL 2F3, except for tough cells in the respiratory and GI tracts. Kind of like ALK, the only cells that normally express ALK are the ganglion cells of the GI tract and tumors. So in this case, this is a tumor. So this is a metastatic small cell neuroendocrine carcinoma with tough cell like differentiation. So PAL 2F3 positive. This patient was later found to have a pancreatic head mass. So these tough cell like small cell carcinomas were first described in the pulmonary literature, and so they were sort of recognized more broadly. And because the tough cells are native to the respiratory and the GI tracts, you know, I guess most other groups that think about. So there's a delay in the papers getting to the GI tract. So I had this case sort of, I think before the first sort of large paper came out about it. But so tough cells are these rare chemosensory epithelial cells. We look at them all the time, but we just don't see them. So there's a normal colon there, and on the right hand side there's actually bronchial epithelium. There's a cilia on top. But that is a PAL 2F3 immunofluorescence stain, the little green cell there. They also secrete IL-25, so that's another way you can stain them, but I think that obviously that's a little less specific than the PAL 2F3. And I guess these cells have a role in parasitic defense as well, so mucosal barrier, immune function. And it's required for appropriate sort of tough cell differentiation. So it's PAL class 2, homobox 3, which is OCT11 or SCN1 alpha. So as you probably noticed, it's a nuclear transcription factor, and those are always nicer stains to look at. Usually they have some trypsin, a little wimpy membranous staining. And as I mentioned, this transcription factor is crucial for tough cell differentiation, which was discovered through a CRISPR screening. So yeah, I'll get more into that later. But so there's been a recent, this was all part of a molecular classification of small cell carcinoma. So the majority, the ones that stand for neuroendocrine markers, as we all expect and hope, especially when there's limited history. There are these ASCL1 high tumors. It's the most common by far. Then there's the second one down is the NeuroD1. Those are the next most common. And there is some hybrid. Some are ASCL1 and NeuroD1. But then there are ones that are negative for NeuroD1 and ASCL1, and they're high PAL 203. And those are the tough cell. So and then there's a even more rare subtype of YAP1. And those often have combined small cell, non-small cell morphology. So small cell with squamous cell carcinoma or small cell with adenocarcinoma, which is sort of interesting. And actually the PAL 203s I think are more commonly combined, small cell, non-small cell. So here's an interesting chart from the paper that really tried to look at the immunophenotypic and morphologic differences between these tumor types. So the ASCL1, by the way, they couldn't really find a reliable morphologic difference. Just this chart makes it seem like maybe that more spindle appearance is more common in NeuroD1, but that's not the case. So it wasn't helpful that way. It's just interesting to see that there are truly these ones that are just ASCL1 predominant NeuroD1, and the PAL is negative for those, and that was very consistent. And the YAP1 ones are negative for all three of those. So it's just interesting to sort of map out. I think the most accepted theory of neoplasia now is the stem cell theory, where there's just progenitor cells that go along different branches. So for some tumors, or perhaps all eventually, we'll map out all the possible paths of sort of the differentiation that occurs in a given tissue type. But presumably only if it has clinical relevance, which in this case there's some early evidence for that. But anyways, the history of it is pretty interesting, as I think all of us know. If it looks like small cell, you can call it. Just make sure maybe it's not lymphoma. Even if the neuroendocrine markers are negative. I know some people won't even do the neuroendocrine markers because they can be negative. And so, but anyways, this Gazdar, actually Dr. Hagen Carney was on this paper as well. They actually showed in cell lines that there were these different types of small cell neuroendocrine carcinoma. But then it wasn't until 2018 that Wang et al. Did CRISPR screening and discovered the PAL2F3 was a tough cell master regulator in these neuroendocrine negative small cell carcinomas. And then they mapped out those four subtypes, consensus subtypes I was mentioning before, and then there was this sort of more careful IHC morphology validation in 2020. And so there is some early evidence for different therapeutic vulnerabilities, and ultimately I guess that's the goal of precision medicine, is to endlessly split every tumor. So it's support for the splitters, at the end of the day, that there could conceivably be technically I guess every tumor in every person is a different thing, but ultimately, and then not until 2022, 2023 was there sort of comprehensive papers about extrapulmonary PAL2F3 overexpressed or tough cell differentiated small cell carcinoma. So I have my case kind of in that window. Not that I was in a hurry to publish or anything, but so they have been seeing the head and neck, GI tract, obviously, pancreatic biliary tract, which was the case with ours. You know, the genitourinary system, that you frequently see some small cells there. Very rare breast examples. So as far as the therapeutic implications, there's some evidence, just cell line studies, but there's sensitivity to IGF-1R inhibition, and you know, the idea that you can target the PAL2F3 transcriptional complex, because ideally, you know, in worst case, you'd just be knocking out some normal tough cells if you targeted the PAL2. Now, it may be, when you really do that, sometimes you find out you're killing more than you planned on. But theoretically, you know, you'd be attacking the tumor and the tough cells, which there's only less than 1 in 100 epithelial cells as a tough cell. But anyways, things can be much more complicated than that. And I like this figure as well, which shows the ChIP-seq methylation, just the different trees. So again, imagining like the target therapies, maybe there'd be different therapies for each of these one there, at least for these big branches, there is already evidence for that. These NeuroD1s are actually sensitive, so these ones are sensitive to platinum, which is the standard therapy for small cell. These ones are more sensitive to another one, I'm sorry, I forget, but and then these ones are that IGF-1R inhibition. So our jobs might increasingly become like doing these markers, so as is already happening, doing all these markers for the therapy, so I guess that's good, but it's only when they ask us to do the stains when there's like not just the wrong context or whatever, but so yeah, when you have small cell morphology and the neuroendocrine markers are negative, I think a lot of people will just call it small cell, especially if it's a lung mass. But you know, when you're outside the lung and you know, you don't have much history, it's nice to have RB, and then PAL2F3. You know, it may not be justified to bring on in every lab as yet, but it can be very helpful for, again, these cases where the neuroendocrine markers are negative, but you're pretty sure it's a small cell. Yeah, and obviously we spent a lot of time looking over the classification and the potential, the new therapeutic avenues. So I've organized the references by sort of the you know, the historical foundation I mentioned with Dr. Carney participating in that study of. It's just amazing there was a 40-year gap until they sort of got back to it. So anyways, I guess that's all I have after that, if anyone has any questions, but thanks for listening.
All right, questions? Yes, please.
Thank you very much for a very nice case. We had one case of pancreatic, very similar case. We didn't do PAL2F3,
Yeah.
but I just want to say it seems that there's also a subset of Merkel cell carcinomas that will be negative for this. I don't think this has been published. I know a colleague who is trying to do a study because he has a couple of cases. So if anyone has any Merkel cell carcinomas that are completely negative for neuroendocrine markers, they are probably PAL2F3 positive.
Interesting, yeah, thanks.
But what are the extrapulmonary? Which organs has it been best described in?
I'm honest. The papers that I showed were sort of they were showing all extrapulmonary sites. So as far as I know, no one's really done like a single organ system outside of the lungs. So yeah, Merkel cells obviously are the challenging differential all the time.
Maybe one comment, because when we're writing the WHO for neuroendocrine carcinomas of GI, there are a lot of debates about whether chroma-synapto combination was required to make that diagnosis, or could you do it only on morphology. I was on the side of insisting for doing it only on morphology, because immunohistochemistry can fail. It's after all a chemistry, and in a hot winter day it may fail, and then you have to go to morphology. Our European colleagues were adamant that we needed those markers to make it neuroendocrine carcinoma. So O2F3 is good because now if they are negative, using this you can make it still a neuroendocrine carcinoma, so at least we came to that point. But what are you guys doing in routine practice? I mean, if your chromosynapto is positive, do you still do routine in every case? And in lung, I'm aware of that classification coming, but are your lung pathologists at Mayo Clinic, are they doing these routinely, neurogenin and O2F and the others to make the classification, or is it just based on patient request or oncologist request? How are you approaching to these new developments?
Yeah, so the pulmonary group is who I learned it from. I see cytology, I do cytology as well, and there's a lot more lung cytology overlap. But anyways, they don't do ASCL1 or NeuroD1. They do the PAL2F3 only if the neuroendocrine markers are negative, and I do that as well on any organ site. And yeah, it's been interesting to see it pan out pretty nicely. So yeah.
That's great. That's our approach to use it when needed. Okay. Any other questions, comments? So now we have a request to collect Merkel cells that are neuroendocrine negative and send it to our colleagues if you have any. Goran, sorry.
Just a comment. I had my first request from our pulmonary oncologist for this, but they were quite happy if we did the RB1 staining, so they were not so sophisticated, but we had a question.
So it is coming. All right. Well, that was very useful. I think if there are no other comments and questions, Dr. Hagen is presenting the next case.
Right, good afternoon. So this case is a patient who was an 80-year-old woman. She had a history of dementia, recent hip fracture, was incidentally found to have an abdominal mass. She subsequently had symptoms of small bowel obstruction and then underwent resection of this mass. On the gross resection specimen, there was a 14.5 centimeter segment of small bowel. This was centrally narrowed to a diameter of 0.7 centimeters. There was a 3.5 centimeter mass associated with this area of narrowing. On cut surface, the nodule was described as tan and fleshy and partially hemorrhagic. The nodule obstructed the small bowel lumen, and there was overlying mucosal ulceration, and we had representative sections submitted for histology. So a low-power view of the tumor, we can see the mass kind of pushing into the lumen of the small bowel, kind of undermining the small bowel mucosa, and then we have kind of overlying ulceration of the small bowel mucosa over the tumor. This is the deep aspect of the tumor, so there was kind of transmural involvement of the bowel wall. We can see that it is pretty well circumscribed, but not encapsulated. A little bit higher power, we can see that it's composed of pretty monotonous tumor cells. A little bit higher power, we see this kind of rich vascularity of the tumor. The tumor cells kind of vaguely have this rosetting or palisading around the vascular structures. There were rare areas that vaguely resembled glandular structures, maybe with some proteinaceous material in the lumens. These were kind of rare and again kind of vague. And then a little bit higher power, we again see pretty monotonous, bland appearing cells, not a lot of atypia, not a lot of mitotic activity. And again, the kind of vaguely salt and pepper nuclear chromatin, but overall pretty monotonous and bland. So I guess at this point, kind of what are you thinking? You can think to yourself, these are some things I considered in the differential diagnosis at this point. And based on that, did a pretty broad immunohistochemical panel covering various lines of differentiation, and most of it was unrevealing except for a few stains. So there was some patchy, weak cytokeratin positivity. Those possible glandular elements that I showed you were actually negative for cytokeratin. EMA was pretty similar. Again, pretty patchy, weak staining. And then CD56 was strongly positive, but again, we know this is a relatively non-specific marker. So at this point, I was kind of scratching my head and decided to submit it for our sarcoma panel, which is a panel that covers the genes listed here. And what we got back was an ACTB Gli1 fusion. And so the final diagnosis was a Gli1 rearranged enteric tumor, which has also been referred to as enteroblastoma. So I want to review this kind of newly described entity and the related gastric entity, gastroblastoma. So Gli1 is located on chromosome 12q. It's a transcription factor and a downstream effector of the hedgehog pathway. Normally it functions in embryogenesis, cell cycle progression, stem cell maintenance, apoptosis, and epithelial to mesenchymal transition. Aberrant activation has been described in many types of neoplasia. So Gli1 neoplasms were kind of first described in 2004. This was a series of 5 Gli1 rearranged tumors that were described as pericytoma with ACTB Gli1 translocation. They occurred in the tongue, leg, and stomach. Because they had SMA positivity, they were considered to have a pericytic phenotype. To date, about 15 similar neoplasms have been described, mostly in the soft tissues, but they have a pretty similar appearance to the tumor I presented. So uniform, round, ovoid to spindled cells with kind of prominent vasculature, a variable, non-specific immunohistochemical profile with variable staining for S100, cytokeratin, EMA, CD56, and CD9B9. And then there's been Gli1 fusions with various partner genes, including ACTB, MALAT1, and PTCH1. And so this is a tumor in the soft tissue adjacent to bone here. But we can see morphologically, again, has a lot of kind of similar features to the tumor I showed you in the small bowel. So pretty monotonous tumor cells, kind of this rich vascularity to them. In terms of the GI tract, there's the probably related entity of gastroblastoma, which was described in 2009 by Dr. Mietin. He described 3 cases of this novel biphasic gastric neoplasm in young adults and proposed this term gastroblastoma. There's about 13 cases in the literature to date. They tend to be younger patients with a median age of 27, but we can see a pretty wide age range. And histologically, they have this biphasic morphology, so spindled and epithelioid cells. Again, very monotonous cell population, low mitotic index, and focal staining for cytokeratin, which is typically strong in those more epithelial elements. And the gastroblastomas that have been sequenced so far have shown Gli1 fusions with the MALAT1. Most of these patients have been treated with surgical resection. Some patients have had liver or lymph node metastases or local recurrence, but overall tend to be relatively indolent. So here's an example of a gastroblastoma where we see the more kind of bland spindle cell components. And then there's areas that have more glandular elements with these kind of tubular-like structures here that have kind of luminal proteinaceous material. So specifically, within the small bowel, there was a case in 2009 that was called an enteroblastoma or duodenoblastoma. And this was a 37 centimeter mass that was in the duodenum of a 22-year-old woman. This was a multinodular lesion. It again had biphasic growth with spindle to round cells and epithelioid elements. The spindled cells were positive for videntin and desmin, and the epithelial component was positive for CK7. It was negative for the SYT-SSX translocation, but further molecular sequencing wasn't performed at that time. And at that time, the patient was without recurrence at 16 months. So fast forward to a few years ago, so we combined the case I presented, the case from the previous slide, and one additional tumor where we were able to sequence all of these cases and kind of describe this entity of Gli1 rearranged enteric tumor. Again, we can see a pretty wide age range ranging from 22 to 80. All of these patients did undergo surgical resection and were alive with no evidence of disease, with follow-up ranging from 1 year to 12 years. In terms of the other cases that were in this paper, one of the cases had a DDIT3 Gli1 fusion. We can see histologically this one again is distinctly biphasic, so we have kind of those spindle to ovoid monotonous cells, and then we have these distinct glandular elements which were strongly positive for the cytokeratin. An additional tumor, again, this one had a Gli1 AARS fusion. Again, this one was pretty distinctly biphasic, where again, there were those epithelioid elements that were strongly positive for cytokeratin. So again, this one was biphasic, and going back to the lesion I presented, we ultimately decided that was kind of more monophasic. It didn't have distinct cytokeratin staining in those epithelial elements, so more going along the lines of a monophasic variant in that example. In terms of immunohistochemistry, again, very nonspecific and variable immunohistochemistry. Again, there tends to be at least some cytokeratin positivity with stronger staining in the epithelial elements in the biphasic examples. So to summarize our findings, this was a unique group of intestinal tumors that were characterized by Gli1 fusions. They tend to be centered in the submucosa, but can kind of show transmural involvement, as we saw in the example case. At a histologic level, these are composed of ovoid to spindled cells with kind of nested architecture, again, very prominent vasculature. They can be monophasic or biphasic. Again, typically a non-specific immunoprofile. Our example of cases had a pretty indolent clinical course with no recurrences or metastases on follow-up. And ultimately, we decided that the preferred terminology for these tumors was Gli1 rearranged enteric tumor. One, because they lack the mallet Gli1 fusions that are seen in gastroblastoma, and blastoma kind of implies an aggressive behavior, which we didn't appreciate in these tumors. Now, there have been a couple additional cases that maybe challenge this definition. So there was a malignant neoplasm in the jejunum of a patient that had a mallet-1 Gli1 fusion. And we can see this tumor is pretty ugly, pleomorphic, abnormal mitoses, so has a really malignant appearance. This patient did have metastases, yet they had a pretty long survival of 26 years. So I think probably this is in the spectrum of the same entity, but maybe a more malignant form of it. Interestingly, the metastases, which were at multiple sites, had kind of more of this well-differentiated morphology. Again, not sure what to make of that, but I guess, interesting that the metastases were more well-differentiated. And then, I guess, to further complicate things, there was a gastroblastoma that was described with an EWS1 CTV1 fusion, so no Gli1 fusion in this case. So, challenging, do we really need a Gli1 fusion to describe this entity, or will we kind of accept additional fusions in the future? So to summarize, Gli1 rearranged enteric tumors are kind of rare biphasic or monophasic tumors we see in the small bowel. They have a non-specific immunoprofile. So far, they're characterized by Gli1 fusions, but likely this definition will continue to evolve as we gather more cases. There's a broad differential when we see something like this. We have a broad immunohistochemical panel to kind of exclude many known entities, but these are tumors we probably have to do molecular testing to make the definitive diagnosis. And again, this is something that's pretty rare. I don't know that I'll ever see another case in my life, but I think it demonstrates the type of case where we really do need molecular testing to kind of make this diagnosis. So when we see something that kind of has a well-differentiated morphology, it's not an undifferentiated tumor, and it has this non-specific immunoprofile, that's when sequencing can be useful to identify these known fusions. So with that, again, I thank you for your attention, and I'm happy to take questions.
Questions, comments? I must admit, this entity was drawn to my attention because of Dr. Mietinen's paper, and you see 3 cases since then. But I don't know how he feels about these now, whether he's willing to make any comments. Would you like to make any comments, Marco?
Yeah, it's so rare. We haven't had since, I think, 2, so now I have seen 5 like cases. Probably will be heterogeneous, yes. We heard here. I have to study them more and see how they go.
Thank you. Great. You have a bunch of these, Candy, in your files, and may I see?
No, I mean, we have a couple gastroblastomas, but this is the only enteric one that I've seen or know of.
Do you think the word enteroblastic is going to make a confusion with those, clear cell adenocarcinomas that have SAL4, clear cell differentiation? Now we're introducing the same term into totally different entities, no? Because these are different than those. I mean,
Yeah.
I like the name. It's plastic. It was a beautiful name coined, but if you use enteroblastic, I'm worried that it will cause confusion between those 2 things. What do you think about that?
Yeah, I mean, I agree. I think that's kind of why we steered away from kind of using that terminology. But I guess, it begs to question, will Gle1 enteric tumor be inclusive of everything? So I don't know, to be determined, I guess.
Yeah. It's great.
May I ask?
Yes.
It's biphasic. Is it biphasic always? Is it always in the metastasis also? And how do you explain the biphasicness?
It's not always biphasic, so I guess the case I showed was considered monophasic. I guess it's hard to say, I guess, what's driving this. Again, probably some stem cell that has dual differentiation. And then the metastases, I guess I don't know offhand. In the example that I showed with metastases, it seemed mostly like the spindle cell components was there, but I guess I'm not 100% sure on that.
I just wanted to make a comment. Recently, we just got a series that has been going around and around because Prostate got the second review after sending the paper back to the American Journal of Surgical Pathology, where we had 3 cases of Rywlin fused with PTCH1. And morphologically, they look very similar to the cases that you have presented. One of these 3 cases had a distinct biphasic appearance and presentation, but later on in the recurrences, it became just like the tumor that you showed. And I find that this type of tumor, as you mentioned, it has a characteristic appearance, but when you go to check your immunohistochemical results, the tumor is all over the place. In GYN, for us, the main thing to consider is a tumor of sex-core differentiation. So we go immediately SF1. And some of the cases can pick up SF1. They can pick up a little bit healing. So they're all over the place. But that nested pattern with the formation of tubules, as you call it, for us, it's microfollicles, because it depends where you are, tubules or follicles. And sometimes they are rather confusing because the follicles, rather than having the eosinophilic material, they have this basophilic loose contents, which really mimics a granulosa cell tumor. We reported these 3 cases, and 2 of the cases had recurrences after 10 years. So I don't know in the GI world what would be the, if you're going to need very long-term follow-up in order to determine what is the true clinical behavior of this disease. Thank you.
Thank you for sharing your experience. And yeah, I think it's hard to make major conclusions with 3 cases and limited follow-up. So I think it's definitely potential that these could have long-term recurrences, like you've noted in G1N tract.
Great, thank you. So actually, Dr. Cooper was set to present the next case. He was on the list for the presentation, but he couldn't make it. A little bit of another significant, it sounds like a little bit of health problem in the family, so he couldn't be here. So I'll be presenting my case, which will be the, I think, last case of the session. So this case was a 66-year-old man, and in radiologic examination there was a well-demarcated round pancreatic mass, and an astute HPB radiologist reviewed this radiology, and the main differential they offered was acinar versus neuroendocrine versus maybe a cystic lesion because a central low attenuated process, but they did not really think this would be a PDAC because of the more roundness and compact growth pattern. And indeed, in resection specimen 2, this was a relatively demarcated lesion, and at the periphery of this demarcated process, you see the more cellular sheet-like configuration with a central necrosis that has this almost geographic necrosis pattern leading to cystic degeneration as well. In the advancing edge of the tumor, in the band that was more viable, we saw this clear cell, almost hypernephroid carcinoma that was high grade, very atypical cells. And there were also scattered bizarre pleomorphic cells within this lesion as well. So when you have something like this is really, you wonder about metastatic renal cell carcinoma that's very high grade or a very peculiar tumor. This is not something that's commonly seen in the pancreas. But in this case, there was also a separate component that yielded the diagnosis or made the diagnosis a lot more straightforward in the sense that there was a conventional pancreatic ductal adenocarcinoma, skirrus pattern, again, tubular infiltration with fair amount of desmoplastic stroma. The glands are dispersed from each other and surrounded by fibroinflammatory reaction, fibroinflammatory process in between them. So we classified this case as poorly differentiated or undifferentiated pancreatobiliary carcinoma. But we have analyzed 30 examples of this phenomenon, which we think is a cohesive entity, and they show a lot of similarities to metablastic breast carcinomas, and I'm going to try to illustrate these to you. And we have presented this in 3 consecutive abstracts in USCAP for its clinical pathology characteristics, immunohistochemistry, and molecular, and I'll try to share these with you in a minute. First of all, this group defines the hallmark characteristics of an ordinary pancreatic ductal adenocarcinoma in the sense that our ordinary pancreas cancer, as I tried to show you earlier in the morning, is really epitomized by a skirrus pattern, scar-like configuration. It's a very ill-defined mass that the radiologists struggle with, saying, is this chronic pancreatitis? Is this cancer? What's happening here? Because it's an extremely insidious infiltration pattern that these tumors display, pancreatic ductal adenocarcinomas. And radiologically, thus, they're represented as these ill-defined, irregular borders, barely visible lesions in the pancreas. And this is a reflection of the tubular infiltration that's widely separated from each other, and there's desmoplastic stroma. But not only that, they infiltrate in a very sneaky, insidious fashion, as illustrated in this example. Actually, some PDACs you may consider like linitis plastica or diffuse infiltrative type carcinoma of the pancreas, in the sense that it can preserve the normal structures quite nicely while percolating through those structures and really infiltrating everywhere. And in the picture on the left, we are seeing the common bile duct is relatively well preserved, but it's actually entirely infiltrated by carcinoma, just like a linitis plastica or signal ring cell carcinoma of the stomach would do. And in the center, you're seeing the duodenal muscularis. It looks intact, but actually there are a lot of carcinoma cells in between the muscle fibers there too. So this is the infiltration pattern that epitomizes, that really characterizes a pancreatic duct level carcinoma. And when they infiltrate to the adipose tissue, because they cannot form compact nodules, you see these separated individual tubules that almost look like embryologic remnants if they're so well differentiated. So in other words, the picture on the left shows what actually our ordinary PDACs typically do. They infiltrate, they may preserve the tissues, and they don't stop somewhere. They just keep going and whatever in front of them. Whereas the group that I'll show to you is distinct in the sense that they stop, they are demarcated for some reason because they have a more compact nodular growth pattern, especially at their advancing edge. So they do have this more demarcated central necrotic growth, leading to these more round tumors in the pancreas itself. And that is due to the more sheet-like configuration of the cells that we see in the lower right picture. Instead of having a lot of desmoplastic stroma separating the carcinoma units, they come together, so they have a more community or more a social attitude, if you will, than our ordinary PDACs, which are really going individually on their own. And again, this translates to a more demarcated growth, not only in the primary tumor, and by the way, this central necrosis is quite striking in these tumors, both radiologically and grossly, and we see the same phenomenon in their metastases. Of course, metastases are often demarcated from whichever organ, doesn't matter, but in fact, PDACs, when they metastasize to liver, they may form compact, round things, but more typically they are more insidiously infiltrating, even in metastatic size, unlike other metastatic cancers in most examples. So the other aspect of this group I'm presenting to you is they are really very analogous to metaplastic carcinomas of the breast in many aspects. Again, metaplastic breast carcinomas, and some of the AMR members did great studies on these topics. Metaplastic carcinomas, breast carcinomas have typically central necrosis and demarcated tumors. I picked some pictures from the internet. I have some cases in my files too, but just to illustrate to you that this is how they are defined. And two of these pictures are actually from the WHO book. And they also show, meaning metaplastic carcinomas of the breast, they are very heterogeneous. They have squamoid differentiation, sarcomatoid, anosquamous, matrix producing, all kinds of different patterns are collected under this heading of metaplastic carcinomata, and they're often intermixed in a given case. And also, as importantly, in the breast, they are basal-like. As you know, luminal basal, big difference these days in terms of the management too, and they are aggressive neoplasms. So I'll show this group in the pancreas in a series of pictures. Please also imagine seeing these pictures from a liver biopsy or a peritoneal biopsy, because that's actually where, for pathologists, this is more helpful. The reason I say that is many of these pictures, if you showed me earlier on, I will say, yes, this could be PDAC, but it's probably not, because PDAC is usually not capable of doing it this way, but it does. So here are these pictures, again, more sheet-like configuration, not much stroma in between. There are vacuolations, and these vacuoles are quite distinctive in the sense that they're multi-cell size. They have signet ring-like morphology. They're very large. They have targetoid granules in them. Some of them show almost necrosis within these vacuoles. Please notice the marked pleomorphism and atypia in the cells. Here's another example showing again these multi-cell size mega vacuoles as an important aspect of their lineage or differentiation or pattern. Some examples, and this is not uncommon, focally show very hypernephroid renal cell carcinoma-like clear cell patterns. And again, if you have this and there's a lot of pleomorphism and monstrous cells, if you have this in a liver metastasis, the PDAC will be probably, or pancreatic adenocarcinoma will probably be one of the last things you normally think, but we really need to start considering it in the differential. Here's another example of a very monstrous large nuclei or several cell size. Some of them, these monstrous cells, have a more wreath-like configuration that you'll see in like Kiwan lymphomas, for example, but please make sure these are not osteoclasts, because osteoclastic type giant cells do occur in sarcomatous pancreas cancers, and that's a totally separate entity, and those really look like conventional osteoclasts, whereas what we have here is pleomorphic, very high-grade carcinoma cell. Some examples have more rhabdoid appearance, and actually, to my eye, this also looked like a little bit choriocarcinoma in the sense that the cell nuclei are hugging the other cells, and their cytologic features, a little bit more squamate, can remind you of choriocarcinomas. And if you do HCG, actually, some of these do show HCG positivity in the large cells. So there is probably some choriocarcinomatous differentiation in some of them. Many of the cases have this cohesiveness that leads to these more rhabdoid type cells, but these are INI1 retained. We don't see INI loss in this group. If we see INI loss, it goes to a different category, and I'll mention that in a minute. Mucoepidermoid features are also seen in this group, and mucoepidermoid actually is a term that I was resisting. Japanese colleagues wrote this paper, mucoepidermoid type carcinoma in the pancreas. Why is it not adenosquamous? It's very high grade. But I've come to realize they have a point in the sense that, yes, this is adenosquamous looking clusters here, but the mature goblet cells, which is not what we see in pancreatic adenocarcinomas, and it's intermixture with the squamous cells here. Now we describe as mucoepidermoid features, and it occurs not uncommonly in this group, just like in the breast. As you know, in the breast, adenosquamous differentiation is very common in metaplastic, or it's one of the main features of metaplastic carcinomas of the breast. And here's an area that, I showed this to pathologist colleagues, and some of them say, yeah, I think this is squamous or squamoid. Others say, I wouldn't call this squamous, this is just an adenoma that is more solid growing. I think either way is fine, but we see these squamoid differentiation in these tumors not uncommonly, and it's just like in the breast, it's a feature of this group. Now, not only the analogy and morphology, but this set also showed basal immunophenotype. In the pancreas, loss of GATA6 or depletion of GATA6 is generally viewed. I don't like relying on immunohistochemistry to make a statement like this, but it's generally viewed as a sign of basal differentiation, and in this group of cases, this is typically either lost or depleted, and in many other cases, you see P40, P63, and CK56 expression that completes the picture of basal-like phenotype, unlike our classical pancreatic ductal adenocarcinomas, which do not show these basal markers. Interestingly, often you have this almost mature-looking, glandular cells and P40, P63 positive clusters. They can even form almost epithelial, myepithelial-like clusters around the glandulars, but these are very aggressive, very high-grade carcinomas after all. Molecularly, these are proving to have higher, we analyzed 16 cases, higher frequency of ARID1A mutation that may prove important. There are targeted therapies that are being developed, some for this molecular alteration. It's being tested in other organs, so it may come to pancreas as well. And recognizing this group, we now suggest, because in pancreas, we really don't have that much ammunition. It's FOLFIRINOX. If the patient has BRCA mutation, which is about 3 to 5% of the cases, then PPAR inhibitors they come into the game with a potential, but usually they don't work that well, and they are used only in the second line. So in pancreas, we are kind of helpless in terms of treatment options, but hopefully when we see this central necrotic demarcated or metaplastic looking carcinoma, we can suggest that maybe a third, a quarter of these will have RD1 mutation, and eventually there may be therapies involved in that group. Other molecular things seem to be slightly different as well. P16 is a lot more common in this group, and KRAS mutation is 100%. KRAS mutation is interesting in the pancreas. It is actually, it's not the mutation itself, but the abundance of KRAS is related to more poorly differentiated cancers. We didn't test its abundance in this group, but it is possible that they will prove to be more KRAS rich, but mutation is seen in every single one, in our experience at least, in this group. SMAD4 mutation was also much less common in this category compared to what is reported in PDAX and TCGA. So there seems to be some molecular differences as well, which may become important, both diagnostically and for management purposes in the future. Now, this group also needs to be differentiated from other more specific undifferentiated or poorly differentiated carcinomas that we see in the pancreas. On the left-hand side, we have, I kept it a little bit long because Dr. Cooper is not presenting anyway, so just taking my sweet time if you don't mind. So osteoclastic cells are seen in sarcomatid undifferentiated carcinomas with osteoclasts. And these are actually better behaving tumors. Some of them are living much longer than your ordinary pancreas cancers. So it's important to distinguish the osteoclastic ones from other pleomorphic undifferentiated carcinomas that we are illustrating here. Medullary carcinoma, just like those in the colon and ampulla, they are MSI high, they are very rare. If you see one, it's most likely ampullary origin rather than pancreatic origin, but they do occur in the pancreas, even in the tail, very uncommonly, and they seem to have better behavior, just like in the colon. And you know, their features, they're more solid, their cytology is distinctive, lymphoplasmatic infiltrates. And then we have this group that I just tried to illustrate to you that I propose to call metaplastic, characterized by GATA6 loss and basal differentiation markers and all the other characteristics of heterogeneity, etc. we described. If you have a rhabdoid-looking tumor in the pancreas, just like in any other organ now, you have to do INI and also probably BRG to determine whether this is a smart mutated or not. We had a paper on this, actually Olga Barstruk had a very nice series that I was also involved in the pancreas, and these are different, and there are targeted therapies for this rhabdoid group as well. We call them rhabdoid undifferentiated carcinoma, INI deficient, possibly smart related if we see it in morphology. So bottom line, just remember a subset of PDACs do not have this serous infiltration but form these more demarcated central and necrotic tumors. Important for radiologists because that's a different differential diagnosis. That means non-ductal tumors for them, but in fact this group does that. For pathology purposes, I tried to illustrate these unusual morphologic features that are important to keep in mind in metastatic sites like liver or peritoneum, and also to keep in mind, you know, we used to think if you have a demarcated tumor in the pancreas, there is more hope for the patient because it may be acinar, neuroendocrine, but unfortunately not all of them. Some of them are proving to be this entity, which is very aggressive. I tried to illustrate the histologic and immunohistochemical phenotype of this group and the importance of ARID1A, which may be, in terms of the management of these patients, may be important in the future. So I wanted to show you a subset of pancreas cancer that seems to be quite different than our ordinary pancreas cancers. You know, we're still studying these, we're trying to understand what they're about, so if you see cases like this, please share it with us and let's discuss. Thank you very much. Questions, comments? How do you all feel about metaplastic breast carcinomas to begin with, right? So it's already a challenging group because there's all kinds of different morphologies and a lot of things collected under one heading. And I was a little bit skeptical and uncomfortable about it, but this group also needs to have an identity, and the analogy with metaplastic breast carcinoma is very striking, so maybe it is. So.
Good afternoon, ladies and gentlemen. My name is Paul Wakely. I'm at The Ohio State University. I will introduce myself to all of you. If you have no interest in cytopathology, you can leave now. If you have an interest in cytopathology, you may want to stay. I don't know that any of you were at the very first AMR International Pathology Slide Seminar. We had that in San Giovanni Rotondo, which is a small town in the Puglia region of southern Italy. Our host was Dr. Michele Bisceglia, and Dr. Michal was one of the people who were there. Obviously, Saul Schuster was one of the people who were there. A couple of other members, I think Dr. Kuhn Cooper may have been there. But most of the rest of you, I can see from your faces, you were probably either in high school or in middle school. Because as you notice the date there, almost to the day, June 20th of 2002, 23 years ago, this month, almost to the day. And as you notice there, Dr. Schuster asked me to give a couple of lectures. And one was on, I'm a surgical pathologist, and I've presented many surgical pathology cases, but Saul will tell you, if he were here, that my real passion is applying the fine needle aspiration biopsy technique, particularly to head and neck lesions, salivary glands, lymph nodes, thyroid gland, and also to this particular area right here, which is soft tissue and bone. We don't see as much bone anymore, but soft tissue pathology. So that was one of the lectures I gave there, and so now 23 years later, I'm going to give you a little bit of an update. Most of this is my own personal experience that I will give for you. So the title of the talk actually is Coupling the Morphology with Ancillary Testing for Diagnostic Accuracy by using fine needle aspiration biopsy to mass lesions of soft tissue. Most people would consider that this is an esoteric practice. So I'd like you to raise your hand. How many of you routinely do soft tissue cytopathology? Nobody raised their hand. So this will be extremely esoteric for all of you. It is also a controversial subject. Many pathologists, surgical pathologists, and even soft tissue pathologists, I know Marcu is not one of them, but many soft tissue pathologists say this is a complete waste of time. Why don't you do core needle biopsies or resections of these specimens and not bother with FNA? Now, the last couple of slides on this talk, I will tell you why we did it in our practice. But it is not common, so it is somewhat esoteric and somewhat controversial. This paper here by Chambers and colleagues from the University of Vermont, you can see it was written about 5 years ago in the Journal of the American Society of Cytopathology. The three major methods of pathologically analyzing mass lesions of the soft tissue are by open biopsy, core needle biopsy, or fine needle aspiration biopsy. And in the interest of time, I'm not going to sit here and read the entire thing. In fact, let me ask you, sir, do the people who are attending here, do they get a copy of this PowerPoint?
Oh, yes, yes.
Do you get a copy of the PowerPoint? Okay, good, so I don't have to read everything here. So you can see in most places in the United States, and I think probably here in Europe also, most surgeons do core needle biopsy for soft tissue mass lesions. I had the unique experience with some of the individuals that I had at Ohio State where we were able to use the FNA technique, and we use it actually quite successfully. This is part of another part of that paper by Chambers et al. From the Journal of American Society of Cytopathology, published about 5 years ago. And you can see the sensitivity, specificity, positive and negative predictive values with the confidence intervals over there. For soft tissue studies, there's another one for bone also. Bone is a little less accurate. But in terms of making a diagnosis of benign versus malignant, it was that type of thing. If I go back one, you can see here, if you look just at the last column under FNA, it is the least expensive technique among the three. Complications are virtually None. Tissue architecture, which histopathologists use on a regular basis, is often lost. The spatial relationships that we use in H&E paraffin-embedded histopathology often are missing or only partially present. Tumor grading is variable, and clinical trials, if you want to do clinical trials in the United States, you cannot use FNA alone. You have to have a tissue specimen, either a resection specimen from an open biopsy or a core needle biopsy. However, in terms of being very efficient for patient management, we have found it is the best technique in our opinion. So what do we do? In this diagram, you can see with a soft tissue mass, we actually separate the specimen into two things. First of all, after I do, and most of these studies that you see, I probably did 90 to 95% of these biopsies that you're going to see. What do? I do 3 passes. I use a 21 gauge needle. Sometimes it's a 1-inch needle, most times it's 1.5 inch, and for deep masses I have used a 2-inch needle. After we expel the material onto the glass slide and make our conventional smears, we then rinse each needle pass in RPMI. Now you can use Hank's balanced salt solution or you can use normal saline. But it's very critical that we rinse the cellular material into the RPMI to gather enough material to get a cell block. So we act not like merely cytopathologists. This is not pap smears where you only look at cells smeared onto a slide. We also act like histopathologists. So after we make our smears, and in my practice we use 2 stains, the Romanowski stain, Romanowski-based stain, whether it's Giemsa, we use Diffquick in the United States, or Makeroon or Giemsa, whatever you use here, as well as the Papa-Nicolau stain, because they give complementary images, so when you analyze the smears. We've even done fluorescent in situ hybridization from smears. Most of the time they're unstained smears, but we've done FNA. The other part is the needle rinse. Once you can create a cell block, or take that tissue, of course, why do we use RPMI? Why don't you use formalin? Because we don't know if that soft tissue mass is going to be a lymphoid proliferation, a lymphoma, and we've seen a number of soft tissue lymphomas. So we want to have material still for flow cytometry. So with RPMI, we can send material for flow cytometry, we can do the cell block, and obviously when we have the cell block, we can do immunohistochemical staining and or a bunch of molecular testing. Even probably, I've not seen any studies, probably this methylation profiling that Mark Kuhn and everybody else is talking about. What are the limitations? There are quite a few limitations. One is sampling error. This is operator dependent. This is not merely poking somebody with a needle and trying to suck back as much material as you can. You actually have to have a technique for performing this. So it is operator dependent. It is also lesion dependent, as you see here. FNA of soft tissue does not work very well when the mass is extremely small unless you use image guidance, or you have to have a discrete edge. I will show you a couple of images on masses that are 3 millimeters and 6 millimeters in greatest dimension that I have aspirated and retrieved diagnostic material. If the mass is too large with central necrosis, and you will get a geode effect, where the central part and all you are capturing is a necrotic material, and the viable soft tissue tumor at the periphery, your needle has gone through, unless you are using image guidance. If the mass is extremely fibrotic or sclerotic, so those of you who may do FNA of lymph nodes, in cases of Hodgkin lymphoma, very large lymph node with the most common form of Hodgkin lymphoma, of course, is NS, nodular sclerosing subtype. Your needle may hit the sclerotic part, and you're going to end up with nothing when you try to extract material from that. So if it's a tiny needle, we'll get into the fibrous connective tissue, and that will plug the needle, and you will acquire virtually no cellular material. If the mass is a swelling or some vague induration without a discrete edge, FNA is not going to work. You're not going to get anything diagnostic. And if it's really very, very cystic and all you get is liquid material, it will not work there. Now, how do I mentally categorize FNA of soft tissue. I look at the most dominant feature, and that's how I subcategorize these. These are either spindle cell rich smears, or they're rich in stroma. They fall into the malignant small rounded cell category or the pleomorphic category. In the interest of time, I have excluded the large rounded epithelioid cell tumors. For instance, epithelio FNA of epithelioid sarcoma. I'm not going to talk about that, and I'm not going to talk about giant cell rich lesions because this is actually a 2-hour lecture that I'm going to try to finish in 40 minutes. So if we look at spindle cell dominant lesions, I look at those with and without nuclear pleomorphism. And then those under those categories, as you can see, I look for background elements, whether there's myxoid stroma, whether there's abundant necrosis, where there's a lymphoid infiltrate, et cetera, and those without background elements, as we see there. And I'm not going to read all of that for you in the interest of time. So here's an example of a spindle cell rich neoplasm. It's from the foot, from an adult. The diagnosis is a schwannoma. Notice how cellular this is. In fact, it's so cellular that some of these are so thick you cannot see in the center. How does this pointer work? You do this? Oh, you can do it. So here you have this, look at these. This is three-dimensional cellularity. Nobody can really, unless you're Superman, you cannot look in here and really look at the individual morphology. You have to go over to the edges where it's less cellular. So if we look at the next slide, you can see these clusters here. And very typical for schwannoma. Most of the time when we think about schwannoma or peripheral nerve sheath tumors, in histology, what do we talk about? Well, we talk about the nuclei are buckling, or spindle shape, or snake-like, or whatever. Actually, on FNA, most of the time, I really don't see that very often. Most of the time, the nuclei are either ovoid, slightly elliptical, and occasionally sinuous or serpiginous, if you will, and even rounded, as you notice here. These typical syncytial clusters, you cannot see a discrete cell border. One cell merges, one nucleus and or cell merges with the next one. So there is no discrete cell border, but if you look at the edges, it's very frayed or fibrillar in nature. There's another image right here. This is a Papanicolaou stain. Shows you the same type of phenomenon. Very bland monomorphic nuclei or isomorphic nuclei, if you will, and the frayed edges. There's another image right in here. This shows you these frayed edges, and most of these, you notice, there's very little serpiginous or sinuous morphology to the individual cells. In some cases, not very often, you may actually capture schwannomas with so-called ancient change. And this can fool you because of the nuclear enlargement, the pleomorphism that you notice there. Even the one on the upper right, you can see there's an intranuclear cytoplasmic, or you have to hold this down. You can see here's an intranuclear cytoplasmic pseudo-inclusion. You notice the occasional isolated or adjacent to these binucleated, very large nuclei. And as you look at this, you may start thinking about a pleomorphic neoplasm. This is ancient change that one can see in schwannoma. Verrucate body formation, very unusual. Typical verrucate body seen in tissue sections on the right-hand side. And you notice those two examples, two different cases of schwannoma, where you get a vague appearance right in here with a palisading of the nuclei. And here's one right over here. Let me show you a case. This is a 35-year-old guy. He had this mass on his thumb for about 2 years, maybe 3 years, and it was not particularly painful, but it bothered him. And he came in, and the orthopedic surgeon called and said, "Oh, will you come over and do an FNA on this guy's thumb mass?" And we have done FNAs of the finger, particularly you get a lot of giant cell tumors, soft parts, giant cell tumor, tendon sheath, I should say. So you can see in this image, now the blue arrow, that's his thumb. The yellow arrow is the mass, and you can see where I poked him with the needle. You can see a little bit of blood right in there. So I poked him 3 times, maybe 4 times, I can't quite remember, and this is what the smear looked like. So you see that syncytial cluster, there are isolated cells there, but notice unquestionably there is now palisading and a hypocellular zone showing to me a verrucate body. I called the surgeon, in fact, let me show you, this is the cell block. So the cell block is right here with the H&E right here. Obviously, a little bit of anissonucleosis that is present here. S100 positive, SOX10 positive. We made a definitive diagnosis of schwannoma based on that. So I called the surgeon back, actually back on this slide right here, and I said, you know, Joel, Dr. Marison, Joel Marison, I said, Joel, this looks like a schwannoma to me. He goes, a schwannoma, Paul, have you ever heard of a schwannoma of the thumb? I said, no, I never have, but after all these years, almost nothing surprises me. So after we did that, then I found this paper, subungual schwannoma. So apparently it does exist. I don't know if, I've never seen another case. So we looked at our material right in here. As you can see, on benign peripheral nerve sheath tumors, we had 89 cases, but of those 89, 65 cases were examples of schwannoma. So you can see in 91% of the cases, we actually made a definitive diagnosis of schwannoma or suspicious for schwannoma, actually 86%. This was the largest series in the English literature, to my knowledge. And you can see what the other diagnoses were that were there. When we reviewed the world's literature at that time, I only selected papers that had more than 20 cases. If it was schwannoma FNA of 5 cases or 15 cases, I did not select. But the references, those 6 references had more than 20 cases. I want you to look at the red circle first. So you look at that, there were 131 cases, or 138 cases. 59 cases that we had right here, total cases. Now, look at the blue circles right there. 69 or 21% were non-diagnostic. That's a very high percentage of cases of FNA schwannoma. 1/5 of the cases were non-diagnostic from the literature. In our study, only 3% of cases were non-diagnostic. Why is that? Are we smarter than other people? No, we're not smarter than other people. The reason is in the red arrow. You look at the ancillary immunohistochemical staining. They only did it in 5% of the cases. We collected material for cell block, and almost 70% of our cases had ancillary immunohistochemical staining. And for that reason, acting as both a cytopathologist and a surgical or histopathologist, we were able to make these diagnoses. Okay, that was one example of spindle cell smears in which the lesion was benign. How about a malignant one? Most people think of spindle cell sarcomas. What's the first tumor they think of? They think of synovial sarcoma, 4th most common soft tissue sarcoma. That's a typical age range, and we all are very familiar with the X18 translocation, and those are the genes that are involved right there. Most of these are monophasic, but a proportion are either biphasic, and there is a very smaller proportion, which is the poorly differentiated variant. This is a histopathology familiar to all of you. The cytomorphology I will show you in a moment, but it looks a lot like a schwannoma. The cellularity is very high. You cannot base a diagnosis of benign versus malignant on degree of cellularity. The cells are present in clusters and in single cells, just like schwannoma. You have clusters and you have single cells. Extreme uniformity, very typical of synovial sarcoma. I remember Saul Schuster telling me synovial sarcoma is like the carcinoid tumor of soft tissue, because one nucleus looks like the next nucleus, which looks like the next nucleus, etc., etc., etc. So the nuclei are typically spindled. Many of them are ovoid. I've even seen them, particularly in cytology, they can be rounded. So this is a case from many years ago. It's a 13-year-old girl. She presented with a mass lesion on the dorsum of her foot. The white arrow shows you about where I put the needle in. And when I put the needle in there, this is what I got. This is a Papa-Nicolau stain. It looks like almost the first slide I showed you for schwannoma. Extremely cellular. So cellular that in areas like this, 3-dimensional, thick clusters, one cannot look in here and look at and identify or evaluate the individual morphology. You have to go down here and look at the material like that. And once you do that, you can see that these are very monotonous or isomorphic cells. They have rounded nuclei, they have ovoid nuclei, some have spindled nuclei. Many of them have minimal to no cytoplasm, very monotonous as the figure says there. Some of them can, in some cases, this is a different case, can show a fascicular pattern. In other cases, you can actually have necrosis associated with it. You notice the viable cells at the upper portion and the necrotic material at the bottom portion. When we did the immunostains, you notice there, at that time, we did not have the SSX immunostaining. It was developed TLE1 positive, CD99 positive, 3-1 positive. We were able to make a specific diagnosis of schwannoma. This paper is from 2002. Actually, the same year where I gave that first talk at the first AMR seminar. These are very well known for those of you who read the cytopathology literature. These are very well known cytopathologists. My good friend Philippe Viel, who's a senior author at the Institute Curie, less than 50% of their cases of FNA were correctly diagnosed. And this is at the time, it was the largest series in the English literature, 56 cases in 36 patients. Less than 50% were correctly diagnosed as synovial sarcoma. That's not the important part of this particular slide. The important part of this particular slide is what I highlighted in green. Only 2 of their cases had any kind of ancillary studies. And what did they do? Cytogenetics. There was no IHC done. There was no next generation sequencing. There was nothing. That's the key to this. Now, when you look at our data, 51 cases with my colleagues from Johns Hopkins, my good friend Syed Ali, who's the director over there, we have, if you look at that, 68% of our cases from 68% of our 51 cases, a specific diagnosis, an unequivocal, and all of these are histologically confirmed. And these are not just the cytologic diagnosis. These patients then have resections or some other procedure where there was histopathologic analysis. So they're all confirmed histologically. 68% were specifically diagnosed as synovial sarcoma, and another 12% were suspicious for synovial sarcoma. So you can see this is more than enough information for the surgeon for a fine needle aspirate, which has almost no complications. You can barely see the needle tract. In fact, you don't even have to resect the needle tract after these we've found in another study. So you can see, what is it, 80%? Almost 80% were either called outright synovial sarcoma or suspicious for synovial sarcoma. And then there are some of the other diagnoses. One was called favored carcinoma, et cetera, et cetera. So this is a doable thing. What about GIST, gastrointestinal stromal tumor? One of the more common sarcomas that occur in humans, in adults primarily. It is by far the most common mesenchymal tumor of the gut that we see, and of course, one of the main authors of all these studies on gastrointestinal stromal tumor is Dr. Michalová, who's sitting over there. About a quarter of these are malignant, but we cannot determine that biologic behavior merely from core needle or fine needle biopsies, and most of them are spindled. A smaller number are epithelial, as you see, and the pleomorphic variant is very rare. Typically, with those 3 stains, 34, CD34, C-KIT or 117 dog1, if you have those as positive, negative staining for particularly smooth muscle and peripheral nerve sheath tumors like leiomyoma and schwannoma, you can make an unequivocal diagnosis. Here are some examples, spindle cell type, 4 different examples. As you notice, Papanicolau stains. This one over here at the lower left shows you almost, instead of clusters of cells, this one shows almost a single cell pattern, this one right here with the diploid stain. You can have this palisading of nuclei, very much mimicking schwannoma or other nerve sheath tumors. This is a cell block from a variety of cases. As you see here, you can collect material for cell block. You notice the palisading right there. This is the epithelioid variant. So we even had cases with the epithelioid variant of this with rounded cells. Some of them have a myxoid stroma. You notice on the lower right, you have that myxoid background from the cell block that's visible with the H&E staining and the epithelioid morphology present here. The little arrows, those of you who are sitting up close can see some arrows here. We even have some intranuclear cytoplasmic pseudo-inclusions in some of these examples. Cell block was positive for dog1 and CD117 or C-KIT, and this was epithelioid type of gastrointestinal stromal tumor. We looked at our data. Dr. Jin was my fellow at the time. She's the first author, and our colleagues again at Johns Hopkins. 97% of our cases, 209 cases, were correctly diagnosed as gastrointestinal stromal tumor. And of those, this shows you 94% of those were primary lesions. These were not recurrences or metastases. These were primary lesions, and then the rest of the data is listed there for you into primary, recurrent, and some of these were called spindle cell neoplasm, a very small percentage, and some were actually non-diagnostic. Now, the latest iteration that's published for the WHO classification of soft tissue tumors was in 2020, 5 years ago. And the authors there, Dr. Detas, Dr. Hornick, and Dr. Mietinen, under gastrointestinal stromal tumor, cytology, not clinically relevant. And yet, we've shown you here that 97% of cases, we can make an unequivocal, these are all histologically confirmed, unequivocal cytologic diagnosis, or cytologic/histologic diagnosis with ancillary staining of gastrointestinal stromal tumor. Now, David Schuster told me yesterday that the new edition, I guess the 6th edition of the WHO classification of soft tissue tumors will be coming out in the next year or two, and so hopefully under the section for cytology, they will no longer say it is not clinically relevant. I don't know whether they'll reference that paper or not. Let's look at stromal lesions or stromal dominant lesions, particularly those that are myxoid. These are just some of the entities. It's not a complete list by any imagination. Let me show you a case presentation. This is a 72-year-old man. He presented with multiple soft tissue nodules in the anterior neck, at level 2, level 3 in the neck, and he's had these nodules for about 3 months. Didn't complain of any other problem. 3 years before this, before he presented with the neck nodules, he was diagnosed with diffuse large B-cell lymphoma, and he was being treated for that. So I did FNA of those neck nodules. This is what the imaging looks like. This is a Michalová stain. Now you see cells in clusters. Some of the clusters have actually a rounded edge to them, but what really strikes you is this material right in here. This stuff right here, very stringy, mucoid type material. Let's look at another image. When we get up closer, these cells have rounded nuclei. They have one, sometimes more than one vacuole in the cytoplasm. Again, you can see that myxoid stroma surrounds not only individual cells, but even clusters of cells. When we look at cell block, it may be clearer to you, those of you who just do histopathology, what it is we're dealing with. Notice the vacuolization. These are very epithelioid cells. You notice the myxoid stroma in the background. We made an FNA diagnosis of chordoma based not only on the cytomorphology, smear morphology, the cell block morphology, and the immunohistochemical staining, which I will show you in just a minute. Here's the rest of the story. After we did the FNA and told them it was a diagnosis of chordoma, they did a CT scan of the neck. That showed a lytic lesion of C2. That was resected, tissue diagnosis of chordoma made. Patient got proton beam therapy, and well as chemotherapy, and it didn't help him. He died of disease 3 years later. This is the cell block with the brachyury stain, and I won't read the rest of the positive immunohistochemical staining that is present there. The anatomic sites of chordoma, well known to almost all of you, and that's the incidence of this tumor when you compare it to all bone tumors. We looked at our data, 47 cases of chordoma, again with Syed from Hopkins. We looked at our cases. 92% of our cases were correctly diagnosed using FNA alone with our cell blocks and immunostaining of either chordoma or consistent with chordoma. Another 4%, so you could take it up to 96% of cases were either called outright chordoma or suspicious for chordoma. One benign nodal cord tumor, BNCT, was called a chordoma. And yet again, the WHO classification, chordoma, cytopathology, is not clinically relevant. Not true. Another myxoid lesion, I will quickly go through this one, EMC, extraskeletal myxoid chondrosarcoma. The name is that from Dr. Enzinger. Before him, Dr. Fred Stewart, the great Fred Stewart from Memorial Hospital, called it a chordoid sarcoma. He never believed it had anything to do with chondrosarcoma. Anyhow, this is the tissue pathology, very typical for those of you who do soft tissue on a regular basis. You can see these linear cords, isomorphic round to oval nuclei, and a thin to sometimes opaque amount of myxoid stroma. This is all tissue pathology. This is not cytopathology that I'm showing you. The immunohistochemical profile there is listed, and the FISH probes. NR4A3, 100% specific among soft tissue tumors for this neoplasm. Let me just show you a couple of the cytomorphologic features. You notice the linear or cord-like profile. If we get a little bit closer to this particular image, sharp cytoplasmic borders in many of these. In fact, there's a little bit of what appears almost a lacunar-like appearance to some of these in the diptych stain. Notice also, I will point out to you this material right in here, this metachromatic staining, myxoid stroma that is present in the background, Papa-Nicolau stain. One of the things that the diptych stain does, it highlights the background elements, whereas the Papa-Nicolau stain, the background elements become much, much less obvious. You can see both clusters, particularly at the lower left-hand side, and notice again the myxoid stroma that's present really pretty much right in here. And again, the cord-like arrangement that one sees with this particular tumor. Here's a cell block on a case of extraskeletal myxoid chondrosarcoma. Again, in the WHO classification, cytopathology, not relevant, yet in our study right in here, 17 cases, you can see we made a diagnosis of either extraskeletal myxoid chondrosarcoma, histologically confirmed or suspicious for extraskeletal myxoid chondrosarcoma in 94% of cases. And I won't stop to go through this flow chart, but it shows you how we went ahead and did this. The one case in which no definitive diagnosis was made, as you noticed, it actually had no ancillary test. And here, this one was called suspicious because the EWSR1 on the cell block was equivocal. The rest of them, you notice, we even had one case where the EWSR1 was negative, but we went ahead and were able to perform the NR4A3 on the cell block and make a definitive diagnosis of extraskeletal myxoid chondrosarcoma. Moving on to the malignant small rounded cell tumor category. And this is a list, a partial list of those entities, as you see here, familiar to all of you, or most of you, I would say. Extraosseous Ewing sarcoma, named after James Ewing right there, chief of pathology at Memorial Hospital many years ago. He wrote that paper back in 1921. Now, adults are affected by Ewing sarcoma more often in the extraosseous as opposed to the osseous location, whereas children in pediatric population, Ewing sarcoma more apt to occur in the bone as opposed to the soft tissue, wide distribution in the body. And this is a paradigm of malignant small rounded cell tumors, or a lot of people like to call it blue cell tumors. I don't like to do that because I can always change the color, but I can't change the shape. So you see, this is a classic example of Ewing sarcoma. Notice the glycogen-filled vacuoles in some of these cells, but most nuclei look pretty much identical to one another. And the cell block showed this data right in here, the H&E, and then the NKX2 staining, PAX7 staining. We know that EWSR1 is not unique to Ewing sarcoma. Some of you, like Michal and Marco, may remember when Noel Widener at an USCAP meeting many, many years ago said, we now have the test for synovial sarcoma. Most of you are too young to remember the way we diagnose Ewing sarcoma. The way we used to diagnose Ewing sarcoma, our ancillary test was electron microscopy. We looked around for the filaments, and when we didn't find filaments, and all we saw was the glycogen deposition, and it was in the bone, and it seemed to fit the clinical picture, we said, okay, Ewing sarcoma. Nowadays, of course, we've become much more sophisticated than that. And EWSR1, when it was first came out, said this is the diagnostic test for Ewing sarcoma. We now know, as you can see from the slide there, that EWSR1 can occur in a variety of entities. Let me show you this another malignant small rounded cell tumor case. This case was only about 3 or 4 years ago. 25-year-old man from Mexico. This is he presented with a 5-centimeter mass on the instep of his foot. And I did the aspirate. Notice here, highly cellular. Again, 3-dimensional thick clusters, as you notice over here in the upper right. Single cell population. So you really can't tell, it really doesn't help you. When I look at cells, when I look at smears, I look for, one of the things I look for is cell arrangement. Just like you do in tissue. You look to see if there are papillae, if there are acinar structures, if there are cords of cells, if it's a solid pattern. You can do the same thing in cytologic smears to a degree. So this one showed just clusters as single cells, unlike lymphoma, where you would virtually never see, you'd never see these clusters of cells in lymphoma. You would see this, a single cell, what we call a single cell pattern. So I knew I was not dealing with a lymphoma just on looking at this pap stain. Go to a higher power, everything looks the same. Another Ewing sarcoma. What, rhabdomyosarcoma can look virtually identical to this. Almost little to no cytoplasm. In some foci, as you see here, there's a bit of an acinar arrangement. It's very uncommon, but it was there. Here's another example. This is now the Diffquick stain. Same type of morphology, and an occasional glycogen, or excuse me, an occasional cytoplasmic vacuole that is present here, but not much else to help you. That's why you need to rinse the needle in RPMI and capture material for ancillary studies for cell blocks. So you can act as a cytopathologist and a histopathologist. So this is the cell block. You notice this right in here. It doesn't tell you much, but now we have material that we can perform ancillary testing. The little yellow star there just shows you an area of necrosis associated with the neoplasm. So what did we do? CD99, positive. NKX 2.2, positive. Okay, are we dealing with Ewing sarcoma? But we did a TLE1, that was also positive. And then we did this stain, which we didn't have in our laboratory up until, what, 3 years ago? Something like that. The SS18, SSX stain, immunostain, positive nuclear staining. So what was this? This was an example of poorly differentiated variant of synovial sarcoma. Also in the differential diagnosis of malignant small rounded cell tumors, along with Ewing sarcoma, rhabdomyosarcoma, etc., etc. Lastly, pleomorphic cell lesions. What we used to call MFH, malignant fibrous histiocytoma. Thanks to Dr. Fletcher, we now know that's an incorrect term, and we call these undifferentiated pleomorphic sarcomas. This is probably number 1 on the list of pleomorphic cell lesions on the aspirates that I've encountered. But you also have pleomorphic variants of this, histologic variants of pleomorphic sarcoma, such as leiomyosarcoma, liposarcomas, rhabdomyosarcomas, MPNSTs, etc., and a lot of other entities that are listed there. Don't forget that pleomorphic lipoma, it actually goes into this list, and it's a completely benign entity, and I've shown you already schwannomas with ancient change. This man is 67 years old. Over there on the right ankle, you can see it's a 6-millimeter lesion. The surgeon called me over, said, "Can you think you can aspirate this tiny lesion from this guy?" He had a pleomorphic leiomyosarcoma on the same leg, above the knee, diagnosed 6 months earlier, or 7 months earlier, as it says there. I said, "Okay, I'll come over." We went ahead, tried the aspirate. This is what we got. The smears in the upper left, you can see the cell block histopathology, and SMA positive, a variety of other immunostains negative. We made a diagnosis of metastatic pleomorphic leiomyosarcoma. Before I move on to the next slide, 3 weeks after this, the man came back with another lesion. It was now 3 millimeters in greatest dimension. So Dr. Marison called and said, "You think you can come over and aspirate this 3 millimeter lesion?" I said, "We'll give it a try." Same type of cytomorphology. After that, the man got a below-knee amputation, and I think he subsequently died from pleomorphic leiomyosarcoma. These two individuals I want to highlight, particularly the individual on the left. Both of them are orthopedic oncologic surgeons. The individual on the left is Dr. Joel Marison, who's the chief of orthopedic oncology over there at Ohio State. He believed very firmly in using this technique. And I want to highlight in the next slide the advantages, and then I'll show you the disadvantages. So the advantages, and this paper was written by a person named Vasquel, and that person actually was Dr. Mayerson's resident at the time. So Dr. Mayerson, Dr. Scharschmidt, and Dr. Vasquel wrote this paper in the Journal American Society of Cytopathology back in 2020. First and foremost, what did they find, the surgeons? These are the surgeons' words, not mine. Efficiency. Core needle biopsy, at least in the United States and in our place, core needle biopsy takes time to set up. You have to gain consent. You have to inject a local anesthesia. You have to then wait on the frozen section to see if you got diagnostic material. Then you have to obtain hemostasis post-procedure. As you see, I've highlighted in yellow, this is eliminated with pathologist-driven FNA. By the time they call me and say, "We need to get Wakely over here to do this FNA," he tells the nurse, "Go in and get the patient consent." So the patient is actually consented by the time I get there. I go over the consent form, have the patient sign again, and I sign it. I explain the procedure to the patient. And then I aspirate the lesion. I typically do 3 passes, and remember, with each pass, I rinse the needle in RPMI to obtain a cell block. I typically do 3 passes. If it's very sclerotic, and I look at how much material I'm getting out onto the smear, sometimes I'll do a 4th pass in some cases. So this allows them, while I'm doing that, to see other patients. It allows the nurse, the orthopedic fellow, the orthopedic resident, remember it's a teaching hospital, so we have fellows, we have residents, and allows the staff to see additional patients in different rooms while I'm doing the FNA in that room. It also allows for same-day insurance approval for staging scans. In the United States, medical care is not free. You're either on an insurance plan from your employer, or if you're my age, you're on Medicare or Medicaid. So they will not approve insurance payment for scans unless they have a pathologic diagnosis, whether it's cytopathologic or histopathologic diagnosis. So typically, after I do the aspirate, I go back to the lab. I do 50% of the smears are stained by DIFQuick. We do the Pap stain the next day. After I look at the DIFQuick stained smears, I tell Dr. Marison, "Oh, this looks like a spindle cell sarcoma." I don't make a definitive diagnosis of spindle cell sarcoma. "Joel, this looks like a spindle cell sarcoma." "Joel, this looks benign." "Joel, I can't tell." No, nobody's perfect, I can't tell. But if I can tell him this looks malignant, I don't even have to tell him it's a spindle cell sarcoma. I can tell him, "Listen, I'm pretty sure this is malignant." He can then contact the insurance company, and the patient can get staged for both chest, abdomen, and pelvic CT at that time. Many of our patients drive 2 hours, 3 hours to come to the medical center. With a core needle biopsy, they would have to go home and then make an appointment to come back 2, maybe 3 weeks later after they have the pathologic diagnosis. So for them, for the surgeons, this is an extremely efficient way to manage patients. It allows for same-day insurance approval for staging scans. Very small masses, often not large enough to accept a core needle biopsy channel. A 3 millimeter lesion, I think, is going to be very difficult to do with a core needle biopsy. I would say most surgeons will not do that, or even that 6 millimeter lesion that I showed you. Resource utilization. FNA is cheaper than open biopsy, as well as office-based and even image-guided core needle biopsy. Let's say we do the FNA and we end up with nothing but an air ball. hairball means we got nothing. Okay? It's still cheaper to do the FNA and then say, okay, we got nothing, now we go to the next step, which is either a core needle or an open biopsy. Safety. Open biopsy has an increased risk from hematoma formation, tumor contamination, and wound problems, particularly if it's done by surgeons who don't know what they're doing. Open biopsy requires excision of all biopsy tracts during a definitive resection. We've shown that that's not necessary for FNA, particularly with a fine needle. An 18-gauge needle is not a fine needle. Relationships. Primary day preliminary FNA diagnosis helps patient anxiety. If I call the surgeon back 20 minutes, 30 minutes after I do the procedure, and I say, this is malignant, the surgeon can go in and tell the patient, it looks like this is malignant. Because what are most people scared of? I don't want to go to the doctor. Why? The doctor might tell me I have cancer. Does that mean if you don't go to the doctor, you don't have cancer? Of course not. So a lot of our patients come in anxious, they're worried they have cancer. Or in other situations, multiple examples where I'll go in and do the FNA, and I'll call the surgeon back and I'll say, oh, this soft tissue mass is gout. They can go in and talk to the patient. And you can see gout, you don't even have to stay in the slide. When you expel, those of you who do FNA, and if you ever done FNAs of gout, when you expel the material onto a glass slide, it looks like creamy white toothpaste. And you can actually just look at the smear under polarization and you can see the uric acid crystals. So I remember one case, well, I won't go into that in the interest of time. The patient was very happy. What are the disadvantages? Same paper. A lot of disadvantages of FNA. It doesn't work if the mass is too large, unless you're doing image guidance, because you will get a geode effect and just sample necrotic cellular material. You have minimal, if any, recognition of histoarchitectural features and/or patterns, the way you do in paraffin-embedded H&E stained tissue sections. The lack of these spatial relationships makes it much more difficult. You cannot see a tumor border. Of course, with a corneal biopsy, you can't see a tumor border either. You can't see a capsule. Mitotic activity is almost useless on FNA. Remember, you're gauging mitotic activity on a paraffin-embedded section that's 4 microns, 5 microns thick. With a conventional smear, you try to make it 1 cell thick, you can't really gauge mitotic activity. It's of no real diagnostic advantage. FNA does not work, as I already mentioned, if the mass is very sclerotic and or fibrotic. It will plug the needle and you will not get any diagnostic material for the most part. If it's a very vascular lesion, I have aspirated hemangiomas, all you get, or for the most part, all you get is blood. You get the vascular channel and that's it. And it also doesn't work if there's a vague swelling or induration. Unless there's a discrete edge to the lesion, like even that 6 millimeter nodule I showed you, FNA is not going to work. You have to have a pathologist who has an interest in soft tissue pathology, which most pathologists don't. Particularly general pathologists in community hospitals, because they rarely see the lesion, because soft tissue tumors are not like breast cancer. It's not like thyroid. So FNA of soft tissue, unlike FNA of the thyroid, salivary glands, pancreas, which is routinely applied in the United States, is very, very uncommonly applied in most centers. Clinical trials, as I said, require a core needle or an open biopsy. An FNA diagnosis, even if you're correct, is unacceptable for most clinical trials. And you always have the risk of getting insufficient material. So if you don't get sufficient material for ancillary studies, in many cases for ancillary testing, you're going to be left with diagnoses of malignant or sarcoma or suspicious for sarcoma or something like that. So this is a very abbreviated talk on the FNA of soft tissue, my personal experience. So hopefully for some of you, you may not, after this talk, think it's that esoteric and that controversial. And I think I'm still within time, so I'd be happy to take any questions or comments from anybody. Okay. Yes, sir.
Relatively little materials. How do you manage the selection of the minerals in each of the categories? We have panels and you apply if it's a one side tumor.
I look at the most dominant feature. Sometimes if it's a mixture of features, like the chordoma, where I see large epithelioid cells and I see a myxoid stroma, that even helps me subcategorize it even more, Alberto. Did that answer your question? Because I couldn't hear the entire question.
For example, you have spindle cell lesion. Spindle cell lesion, you don't look the same. You got like 4 or 5 immunostains and
Oh, I see. Yeah, what's my initial immunoprofile? It depends on the clinical scenario. Obviously, if it's an older patient, I might think of one thing. If it's somebody in their 20s, I might think of something else. But what I would probably do is common things happen most commonly. So if I have a spindle cell lesion, I'll probably do an S100 first. And I'll probably do an S100. I will probably do, now that we have the SSX immunostain, I will probably do that. I will probably do a muscle marker, a myogenic marker, SMA, a Desmond, probably, right off the top of my head. And I almost always, even with a spindle cell lesion, I almost always do a pan-keratin marker, just to try to get that material up front. I might even ask for unstained slides at the beginning, because most of these cell blocks, we don't have much material we're dealing with, so it becomes very precious material, and I try to be very judicious as to what stains I'm ordering. And hopefully with those 5 or 6 markers, depending on one of those being positively stained, then I can go on with a second tier of markers to become even more specific, or ask for molecular analysis on some of these. Yeah. I don't know if that answered it or not. Any other questions or comments? Okay, thank you very much.
There is no moderator, so I'll take microphone, and I would like to express my gratitude and appreciation to Paul. And now we continue with the second lecture, which will be presented by our colleague Robert Slunecko. I don't know if I should introduce him. You will introduce yourself.
So thank you very much. I'm working as a pathologist here in Bioptická around 16 years or something like that, and I specialize in urologic pathology and mainly prostates and urothelial carcinoma. 2 years ago, we started working with AI, and since then AI is everywhere. I think even now Brett needs to have some AI because it's a modern hip word. So everybody needs AI, and in medicine, mostly pathology and radiodiagnostics are the clearest fields, because all we do is just looking at pictures, nothing more, and evaluating pictures. And years before AI, we had some computer image analysis, which were narrowly tailored programs just for like nuclei counting, immunohistochemistry, and so on. So in AI-driven programs, we have really easy to use, but very, very hard to train large models. So I asked AI to make me some pictures of the AI-ruled world. And I don't know why, but most of them look like this. So maybe Skynet is coming. In prostate or any other AI program, we have 2 advantages or disadvantages. First is administration and working with AI and digital pathology. You need good LIS implementation, you need large image storage, pay for cloud, pay for local, you need really good scanners, would you use glass slides still, or would you use paper forms? You need time for training and really good monitors with nice resolution and contrast, and really massive data pipeline. If you don't have good internet connection, everything will be terrible. And of course, you need really good IT management. And again, it's not. I'm an old school pathologist, so I really love my microscope. So when I look in the monitor, it's a really different feeling. It's not so pleasant for me, let's say, but you get used to it. The main functions, let's say there is one main function of any AI program, and it's the detection system, the large trained detection system, and with that you get some special features like the assessment of Gleason score, looking for perineural propagation, high-grade pain, and so on and so on. But the main thing is the detection system. So our offices just do not contain just the microscope anymore, and we need more and more monitors. The detection system with prostate, it has really nice positive predictive value, over 99%. And all you got is a 4-tier system. If there is nothing marked on any slide, it's you can be almost certain it's benign. We didn't get for the 2 years any slide with carcinoma which wasn't marked. Then you get the green tier, which mostly is benign, yellow, which is 50-50, you can decide, and red, which you can be almost certain you have carcinoma. Again, it's not diagnostic system, it's just detection system. It gives you probability and shows you foci, small, large, and probability of carcinoma from the most benign green to mostly carcinoma red. We have over 2,000 cases with over 23,000 slides evaluated, over 15,000 in green, and just 110 carcinomas. And in red, we had almost 5,000 slides with carcinoma, and only 13 were benign. In the medium, you got 2/3 cancer, so let's say 50-50. Sensitivity, specificity, and the predictive values are really high. So what you will get? In case there is nothing marked, you get just the slide, you can look over the slide, you can look over the slide in your microscope for the physical slide, and mostly you won't see anything. We didn't find any carcinoma on this slide yet. When you have the green tier, then you get something like that. This is benign case, just some partial atrophy, some, let's say, a little bit crushed glands, which were marked by the system like that. If you want, you can get immunohistochemistry. In this case, it wasn't necessary. You can get a malignant case in the green tier, and like that you get slide, and just one focus, let's say 1 millimeter in diameter, which is marked, so you can be almost sure that there is nothing on the other spaces. And when you look at the slide, then you see just 2 malignant glands. These were, we used immunohistochemistry for them just to be sure. Or like that, you get a large needle biopsy with just one focus. It's a little bit suspicious glands. You get to see just one line of cells, a little bit of blue mucin, maybe some nuclei, but nothing more. And in immunohistochemistry, carcinoma. Then the 50-50 yellow tier. you get these, let's say, maps. It could be large or small foci. The more red, the more it is sure it's carcinoma. And again, it could be malignant, it could be benign. It's upon the pathologist. And in this case, it's nice 3+3 carcinoma. You can get it without any immunohistochemistry. You can get minimal carcinoma, like here, which is small focus of 4+4 carcinoma, marked like this, and it's just 0.4 times 0.2 millimeters. So when you are at the end of your day after 10 hours and more than 100 cases, you can miss something like that. You shouldn't, but we are only human. And then you can get some weird yellow marked foci, even out of any tissue, just somewhere on the slide, which are completely benign. In this case, it looks a little bit suspicious. Again, some blue mucin. You can't really be sure about any basal cells, so in immunohistochemistry, completely benign. And then when you get the red one, you get straightforward carcinoma, like here or here. And again, you can get some minimal foci, like this, straightforward 3+3, which looks like that. You wouldn't miss it anyhow, or you shouldn't. It can help you with looking for perineural propagation, which can be fun sometimes, but really clinicians mostly say it doesn't matter, they don't care, but you should look for it. Then you get marked propagation like this, or even in these crushed edges where it can be sometimes problematic, and again marked like this. But the fun starts with Pilsen. Overall, we can say it's a good experience. It's going to get even better with some new versions, but still the AI has tendency to overgrade, mostly overgrade 3 to 4, 4 to 5, but sometimes it even can grade 3 to 5 because the AI doesn't look at the picture as a human. We look at the structures, we see some poorly differentiated glands, some nice 3 glands, single cells and so on, but we can imagine what comes next. We can look on deeper cuts, and we can imagine, oh, this is not really poorly differentiated, this is just the edge of the normal nice gland, so it's still 3+3, but AI just sees only the one picture, can't see and let's say can't put together any other deeper cuts, and it really doesn't even see cells or the glands, it's just zeros and ones. And sometimes it's a little bit mystery on how it, let's say, how it was really trained, what it understands as cancer, because it really depends upon contrast, color and so on, that's translated into zeros and ones. The textbooks examples are mostly okay, but the troublesome in-between cases that really depends only upon pathologists, and as you know, these are troublesome even not between 2 pathologists sometimes, but even if you look at them in the morning or in the evening, you can disagree with yourself. So the concordance is nice. At least almost 80% is complete concordance, and from the 20%, 95% is difference of just one Pilsen group, and 5% difference of 2 or more. So, nice, straightforward 3+3, and then again you get the map of the AI, which dark blue is straightforward 3. Let's say green, because I see just 9 colors or something like that, is 4, and dark red is 5. You get in between like the light blue, let's say, or orange, but again, the AI will give you mostly blue, says 3 plus 3, and this is straightforward. You can get a nice 3 plus 4 mixed up, where you see nice glands of grade 3, and in between the poorly differentiated grade 4. And in blue you get the 3s, in let's say green to orange you get the 4s, so no problem there. But something like that seems to be a little bit of problem, because it really can't understand how the deeper cut works. So like in, let's say, here. Here you get a nice 3 plus grade 3 gland. Here you get grade 3 gland. And then when you see those glands are marked as orange or red, so it really thinks it's grade 4. So you really need to look after the AI, and you really need to see what the AI is telling you and what is there. 4 plus 4, straightforward, cribriform, nice things. 4 plus 4. Again, don't be panicked by some blue spaces, because you will get the Pilsen score recommended from AI. Again, control it. And again, a little bit troublesome. Is it 4? Is it 5? For me, I see some single cells, mostly poorly differentiated. For me, this is straightforward 4 plus 5. But in AI, you get 5 plus 5. So again, you really need to look all over the slide. You just can't click on anything that AI give you. The diagnosis is upon you. 5 plus 4 or 5 plus 5. I see again some poorly differentiated glands, some, let's say, more single cells in there. But the AI sees only 5s. So again, you need to control everything, but the AI really helps. And nice, straightforward, 5 plus 5, solid sheets. You get, again, 5 plus 5, nice. You can get some help with a little bit of high-grade pain, marked like that. You can get some help with looking for atrophy and inflammation. But let's say the inflammation mostly is for clinicians something in cases where there is high PSA with high PHI index, and there is no carcinoma. You can get granulomatous prostatitis, you can get some active prostatitis after, let's say, biking or something like that, and then you get a high PSA. After that, you can give your clinician nice final report, but I have to say the final report isn't from AI, it's completely from pathologist. The AI helps you to look for small foci you could miss. It helps you with Gleason score. It helps you with everything, but it doesn't control you. And for me, still there is no future where we have, let's say, really diagnostic system like from Star Trek and something like that, because all we have, even in radio diagnostic, everywhere you get just detection, no diagnosis, and no company would try to make a really diagnostic system right now, because they would need to sign out the biopsies, and after some mistakes, who would be blamed? Company, AI, somebody should control it, something like that. So right now, really helpful detection system, but not diagnostic system. And a little bit of sneak peek, because we are not finishing with, let's say, prostates. We are preparing the same for breast cancer, and right now we are starting even urologic cytology. And who is doing cytology from urine, mostly 10 or more cases daily, you know that cytology can be really tiresome. Mostly when you are looking specifically for one thing, cancer, you are looking again for everything. But when you have urine, in 99.9% you are looking for urologic cancer, normally nothing more. You can see some other malignancies, you can see lymphoma, spindle cell, and so on, but these are really rare cases. You are looking for urothelial carcinoma. And it's really tiresome after some slides. You don't want to look at any other cells anymore. So we are starting with this system, which looks a little bit like a gynecologic system from Logic. You will scan the slides that should be LBC slides, and then you get the evaluated gallery of every cell, which are the most suspicious. You get the 20, I think 24 most suspicious cells, but you can look on every cell, and with every cell you get precise measurements, which till now I was completely eyeballing. I couldn't measure if it's their NC ratio of 0.5 or 0.6, because for me, for my eye, I think I can decide, but I wouldn't bet my hand on it, not even head. You have the nuclear area, and which is very nice for me. You get the cytomorphologic features on every single cell. So the hyperchromasia, membrane, coarse chromatin, and so on, everything is presented with every cell. And if you click on that cell, you get transported in the slide. You see the cell with everything around it, and you can even highlight the cytoplasm and so on. Again, this is just detection system, because you can get suspicious cells with completely benign cases. You can get low-grade cells with a little bit more high-grade. You can get high-grade almost without atypia in urine. So you have to think, you have to see what's on the background, you have to think if it's just a spontaneous urine or bladder washing with atypia, reactive atypia, and so on. So it's a really nice and precise detection and measurement system with some nice features like the hypochromasia. As you can see, it will show the coarse chromatin, irregular membrane. It will highlight it for you on the slide. It works like just a really nice cytology technician which looks over the slide, makes some points, show the slide to you, and says, look at those cells, these are really, really bad, and you really can't just exclude all the other slide of the slide. You have to look for everything. Right now you can't depend that the AI will make diagnosis instead of you. It will help you detect something, but the diagnosis is only upon you. You are signing out. Some examples of suspicious cells or completely positive cells with high NC ratio, big nuclei. I think nobody would miss those cells in urine. Maybe if there was just one or two, but you shouldn't miss something like that. And of course you can scan all over the slide on the monitor, but still for me, microscope is the number one. I feel much more better when I can look on the slide, then I can compare my eye to AI, and then I can make a diagnosis. You can click on every atypical cell, and it will show it to you with all the NC ratio and so on. And let's say AI in the Paris system is starting to be a little bit necessary, because right now there are debates of the thresholds, of the atypical, of suspicious. There are two thresholds, 0.5 for atypical and 0.7 for suspicious. You need to get, of course, 1 or 2 morphology criteria for atypical and 2 or 3 for suspicious. But right now there are debates that 0.7 is too much, that we should lower the threshold to 0.65. And for me, I don't know any human that just with their eyes can see difference between 2 cells that are 0.65 NC ratio and 0.7. Nobody can. I think even 0.6 to 0.7 is for human eye impossible. It's your personal feeling with experience that makes diagnosis, and the measurements will be much more appreciated, but still, AI is coming for the Paris system, and for us as pathologists who are looking over urine cytology. And I don't think that in, let's say, 3 to 5 years you will get without the precise measurements, because the clinicians will want it. They will want the definite, they don't want much of the atypical diagnosis. It's the worst diagnosis for clinician you can get, because they don't know what to do. Is there carcinoma? Isn't there carcinoma? You can say, I don't know, maybe, maybe not. But with, let's say, more precise measurement, you can get more benign and more suspicious. And again, I asked AI to make me some nice pictures of AI-driven medicine and hospital. And I have to say, this looked to me as scary as the first one, because I wouldn't want to lie on the table right now. This is really, really far, far future. We are still needed, and as we will discuss it later, I think on the 3rd day, pathologists are needed. There isn't a near future with only AI diagnosis. The people will be needed and will make those diagnoses, not AI. It will help us. It will, let's say, shorten our time with the biopsy, and it's a little bit less tiresome to look over slides for 8-10 hours, and in the evening you are completely crushed, and still you can see at least something what AI shows you, because you can look for just small spaces, small foci, and the rest just, let's say, I will eyeball it a little bit less. So, thank you. And yes?
Take that.
Okay. Thank you. On your prostate biopsies, if the AI shows no coloring, do you even bother to pick up the slide and look at it under the microscope?
Yes, I can't sign out case which I didn't see. I'll be quicker, definitely quicker, but I can't sign out any even small focus I didn't see. I will look all over the slide. I will be quicker in the benign, straightforward cases, or the, let's say, there is everywhere 3+3. I will get the measurements immediately. So I will be quicker, but you have to look on all the slides, every focus, every time. You are the one who is making the diagnosis, not AI. AI is something like immunohistochemistry, and would you say it's a positive immunohistochemistry just through windows? You can sometimes, you see just black, yeah, definitely positive, but would you do it anyway? Just look like that, and yeah, positive. So, it's the same in AI. Yes, it will help you, but it's not the system that makes the diagnosis, never.
Thank you.
Hi, excellent presentation. Regarding prostate biopsies, what about other types of tumors? So first question,
yes.
And another one, seminal vesicle tissue in core biopsy.
Yes. So seminal vesicle tissue, completely benign. The system knows how it looks like, and there's no trouble. But rare carcinomas, that's something different. Everything we saw, like small cell carcinoma, urothelial carcinoma, even lymphoma, and so on, everything was marked as carcinoma, but the system, with high confidence, marked it as acinic carcinoma. And it's okay. So again, you will get marked carcinoma. It will be sure it's malignant, but you just can't see, carcinoma, never mind. You have to look at it, and you have to make sure it's really acinic carcinoma, it's not something special. It's better with ductal carcinoma, which it recognizes, but the rare variants, it depends on how it is trained. You can get acinic carcinoma everywhere. Thousands and thousands, millions of slides, no problem with training. But how much slides of small cell carcinoma in prostate can you get? Few. Maybe hundreds, if you have some friends around. But mostly you will call some firms to get you slides, you get some, but can you get, let's say, 10 to 100,000 of slides? No. So the training of the AI, it doesn't think. It can't imagine that, yeah, these are small blue cells. I have to think about small cell carcinoma. Yeah, there is some crash artifact and so on, no cytoplasm. All you can get is, yeah, carcinoma, nothing more. So always you need to make sure it's like in 99.9% acinic carcinoma, or let's say ductal carcinoma. You have to make sure it's not some weird variant like urothelial carcinoma, or some even more rare special thing which you will see once in several years, and the AI doesn't know it. They won't be trained for these things a long time, and it depends on the type of training of AI. It depends on the number of slides and the type of training. If there are pathologists, there are signing those foci and showing, yes, this is carcinoma, yes, this is grade 3, and so on. Or if you let the AI think for itself and just say, these are carcinoma, these are benign, and work it out. Even this training is possible, but you get different results, sometimes interesting, but nothing is possible without your eye and your final diagnosis. If you sign out something like that, then God bless you, because you will need him.